Hi, this is Dr. Andrew Xavier, Assistant Professor from Department of Pharmacology, and I welcome you all to this integrated teaching session on viral hepatitis. And now we will move into the pharmacological aspects of viral hepatitis. So, at the end of this session, all the phase 2 undergraduate students should be able to explain the treatment of viral hepatitis of A, B, C, D, and E, and should be able to classify the antiviral drugs used for the treatment of hepatitis B and C, and explain the vaccination and precaution strategies available for viral hepatitis. So this session we will more concentrate on hepatitis B and C because these two are the infections which will require antiviral drugs for its treatment. So coming to hepatitis B, we will look into how the virus is going to do this replication and how the drugs are going to act against which stage of replication to control this infection. The hepatitis B virus enters into the cell using this through this NTCP, that is sodium taurochloride cotransporter polypeptide. After entering into the cells, it leaves this circular DNA, which has to get transformed to this positive strand DNA from this negative strand DNA. So this positive strand DNA formation is highly necessary for the normal functions or replication and maturation of this hepatitis B virus. And thus, inhibition of this production of positive strand DNA will be the mainstay of treatment. We have drugs like entecavir, lamivudine, adifovir, telbuvudine, and tenofovir. So what each drug does is with the conversion of this negative strand DNA to the positive strand DNA, and this inhibition of this positive strand DNA directly interferes with the normal maturation of this hepatitis B virus. So now we will look into the individual drugs. The first drug is interferon, which has antiviral and anti-proliferative effects. It stimulates cytotoxic activity of lymphocytes, natural killer cells, and macrophages, and also upregulates the MHC expression in the cells. So these two activities tend to increase the effect of lymphocytes and natural killer cells against these cells infected by the virus. It also inhibits the protein synthesis in cells, which is highly required by the virus to produce its structural proteins, and thus has an inhibitory effect on virus. So interferons are common used for hepatitis B and hepatitis C infections, and the common adverse effects of interferons are fever, chills, proteinuria, alopecia, and myelosuppression. Regulated interferon is an formulation which is available that has very less side effects compared to the standard interferon. And we also have other drugs like entecavir and tenofovir, where entecavir and tenofovir is the first line drug. Entecavir is an guanosine analog which is given for patients of age more than 2 years, and it is mainly the first line agent for treatment of patients with cirrhosis. The common adverse effects are lactic acidosis and hepatomegaly. So tenofovir is a acyclic nucleoside phosphonate compound which has a good safety and efficacy profile compared to entecavir and other group of drugs. So the two prodrug formulation available for tenofovir is tenofovir disoproxil fumarate and tenofovir alafenamide fumarate. The adverse effects with tenofovir are headache, cirrhosis, and insomnia. There are also other drugs like adifovir, lamivudine, and telbuvudine, and all these drugs, when suddenly discontinued, can lead to acute hepatic flaring of infections. So, the adverse effects of adifovir are asthenia and impaired renal function. For lamivudine, it is sore throat and other ear and nose infections, and for telbuvudine, it is myalgia, fatigue, and diarrhea. So coming to hepatitis C infection, hepatitis C, as like hepatitis B, get inside the cells, releases its nucleic material, and this acts on the endoplasmic reticulum to produce the structural protein necessary for the hepatitis C virus. And here in endoplasmic reticulum, there are various non-structural proteins like NS3, NS4A, NS4B, NS5A, and NS5B, and all these takes part in the production of the viral proteins. The main function of NS3, NS4A is to cleave these proteins and make them more into the active stage. And the function of NS5A is in replication and NS5B is in the RNA polymerase enzyme. So these are the drugs, that is NS3 or 4A protease inhibitors are glecaprevir, grazoprevir, telaprevir, and oxalaprevir. And the drugs that acts on NS5A are declatasvir, ombitasvir, and ladipasvir. And the drugs that inhibit NS5B polymerase are dosabuvir and sofosbuvir. Whereas there are also other drugs like interferon, peginterferon, and ribavirin that acts against this hepatitis C virus. So usually this direct acting antivirals are used in combinations like sofosbuvir is combined with ladipasvir or declotazvir or with velpatasvir and oxaliplatin. The common adverse effects we can suspect is headache, fatigue, and diarrhea. Ribavirin, as told before, is also used to treat hepatitis C in combination, and the common adverse effect with ribavirin is hemolytic anemia and teratogenicity. Thus, it is contraindicated in pregnancy. So coming to the pharmacotherapy of hepatitis B and C in their acute and chronic stages. For acute hepatitis B, it is about supportive management, and in some cases, the patients are indicated with antiviral therapies such as tenofovir and entecavir monotherapy. Interferons are usually not preferred for acute hepatitis B. In case of chronic hepatitis B, it requires other investigations like hepatitis E antigen, HBV DNA, and ALT levels. If the ALT levels goes more than the two times the upper limit of normal, even if the hepatitis BEAG is present or on the levels of hepatitis B V DNA, the drug treatment, antiviral treatment should be started. And if hepatitis BEAG is positive and the ALT levels are less than two times of the upper limit normal, we have just to monitor the patient. So coming to the pharmacotherapy of acute hepatitis C, the direct acting antivirals are initiated earlier for hepatitis C infections, and the preferred combination is sofosbuvir and velpatasvir for 12 weeks or glecaprevir and fibrentasvir for 8 weeks. So this is the flowchart of how pharmacotherapy of hepatitis C is done. First, the patient is look for clinical signs suggestive of decompensated cirrhosis like ascites, encephalopathy, jaundice, and variceal bleeding. If these factors are present, then antiviral therapy is initiated, and if they are absent, we have to look into the genotype of hepatitis C and the presence of any cirrhosis. If the genotype 3 is present, then the drug indicated is glecaprevir and fibrentasvir for 8 weeks. If there is absence of this genotype 3, then the patient is started with sofosbuvir, velpatasvir, or glecaprevir and fibrentasvir. Hepatitis A is a self-limiting infection and thus only needs supportive care for treatment. The patients usually fully recover for within 3 months, and 85% of the patients will recover. In case if they goes for fulminant hepatic failure, liver transplantation is done. Hepatitis D usually coexists along with hepatitis B, and thus active treatment of hepatitis B with antiviral is necessary for eradication of hepatitis D infection. In case fulminant hepatitis detected, liver transplantation has to be done. Hepatitis E is again a self-limiting condition in acute cases, and very rarely in immunocompromised patients they can go for chronic infections. So to treat this disease in chronic stages, the conditions or that is leading to the immunocompromised stage in patients is being treated first. And if the HEV RNA persists for more than 12 weeks, ribavirin is initiated in this patient. So that is with the management of hepatitis A, B, C, D, and E. Now, getting into the precautions of viral hepatitis, we have vaccination strategy and post-exposure prophylaxis. Vaccination is available for hepatitis A and B, and hepatitis A is the inactivated vaccines under the name Havrix, Vaxta, and Pinrix. So the dosage is given through intramuscular route, and it is 0.5 ml for children on 0, and second dose is from 6 to 12 months. And for adults, 1 ml intramuscular injection is given at 0 and 6 to 18 months. Hepatitis B vaccine is a recombinant hepatitis B vaccine that comes under the names of Recombivax HB, Energix, and Heplisav. And it is given through intramuscular route, and 0.5 ml is given at 0, 1 and 6 months for pediatric age group, and 1 ml is given at 0, 1 and 6 months for adults. So post-exposure prophylaxis is more common with hepatitis B infections, and this post-exposure prophylaxis is administered through hepatitis B vaccine and hepatitis B immunoglobulin. Ideally, this post-exposure prophylaxis should be started within 24 hours, at least within 7 days of the exposure. So that is about the treatment and prevention of viral hepatitis. Thank you.